Good afternoon. My name is Hannah Shepard, and I'm a CSTE Applied Epidemiology Fellow hosted by the Center for Birth Defects Research and Prevention at the Massachusetts Department of Public Health. Today I'll be presenting our work entitled Estimating the Sensitivity of a Pilot Neonatal Abstinence Syndrome Surveillance System in Massachusetts using Capture-Recapture methodology on behalf of myself and the rest of our study team, including Dr. Masa Yazdi, Dr. Susan Manning, and Dr. Irini Nestoridi. So the objectives of this presentation are to first provide some background information on the etiology or causes and common symptoms of NAS, then to present some information on the incidence of NAS over time at the national level and in Massachusetts, and then third I'll discuss some of the key challenges to NAS surveillance. And then next I'll outline existing sources of NAS data in Massachusetts. Fifth, I will introduce our pilot active NAS surveillance system, and then I'll move into describing the capture-recapture analysis we performed to estimate the sensitivity of our NAS surveillance system. And then finally, we'll recap takeaways and discuss next steps. So some background on the etiology of NAS. It is a newborn syndrome or a constellation of symptoms that is caused by the sudden discontinuation at birth of in utero exposure to substances used by the pregnant person during pregnancy. The most common in utero exposure associated with NAS is opioids, but in utero exposure to anxiolytics, sedatives, and barbiturates are also implicated in the development of NAS. And these substances can be both prescribed and not prescribed. Common symptoms of NAS may involve the central nervous system, with symptoms including hyperirritability, high-pitched cry, jitteriness, and tremors. The gastrointestinal system, commonly poor feeding, regurgitation, vomiting, and diarrhea, and then the autonomic nervous system, predominantly tachycardia, tachypnea, and hyper or hypothermia. So from 2010 to 2015, we saw a steady increase in the incidence of NAS in the US, rising from around 4 infants diagnosed with NAS per 1,000 hospital births in 2010 to around 6.8 infants in 2015, which is the last year the ICD-9 codes were used. And then after the introduction of the ICD-10 codes, we saw an initial increase in the incidence of NAS that started to decline in 2018, which is the most recent year for which we have data. And it's hypothesized that this increase in the incidence of NAS has been largely driven by the opioid epidemic in the US. Of note, however, there has been tremendous variation in the incidence of NAS between states, with estimates ranging from a low of 1 to a high of 48 infants with NAS per 1,000 hospital births. And I'll discuss some of the potential reasons for this variation later in the presentation. Now looking at the trends in NAS in Massachusetts, from 2010 to 2015, we saw around a 50% increase in the incidence of NAS from 10 infants diagnosed with NAS per 1,000 hospital births in 2010 to around 14.8 in 2015. But the incidence has declined since 2016. However, this decrease occurred concurrently with a change to ICD-10 codes from the ICD-9 codes, so this might account for some of this decrease. So, however, compared to the national NAS incidence I just shared, we see that the incidence here in Massachusetts is 1.5 times as high. So there are some major challenges to NAS surveillance. For one, NAS isn't a nationally notifiable condition, and it is not a reportable condition in most states. And this has led to some variation in the incidence of NAS, as some states are required to report cases of NAS, while others might not have any surveillance infrastructure for it at all. Moreover, there has not been a standardized case definition for NAS used within and across states. And due to a lack of clinical consensus in what constitutes NAS, the clinical case definition varies not only between but also within states. And then finally, there are differences in the terminology that's being used to describe NAS. So some use neonatal opioid withdrawal syndrome, or NOWS, interchangeably with NAS, while some clinicians and reporting entities view these as distinct conditions. And in Massachusetts, there are a few existing passive population-based sources of NAS data. So at the Massachusetts Department of Public Health, the Bureau of Healthcare Safety and Quality collects aggregate-level NAS data from hospitals. We also have a state dashboard that includes NAS data from the Pregnancy to Early Life Longitudinal Data System, but it's delayed by about 4 years, which is also true of the All Payer Claims database, which can take a few years to gain access to. And then finally, Massachusetts birth certificates implemented a checkbox in 2019 to capture NAS, but there's a lack of standardization across hospitals in how this checkbox is being utilized. So as you can see with all of these systems, there are either issues with timeliness, standardization, or really limited to only aggregate level data. So now I'll move on to describing our pilot active NAS surveillance system in Massachusetts, which seeks to fill some of these gaps. Given the challenges to NAS surveillance that I mentioned, CSTE convened an NAS work group in 2017, and they worked to develop a standardized surveillance case definition for NAS. They then provided funding to a group of awardees, including our birth defects monitoring program in Massachusetts, to pilot NAS surveillance using their case definition while leveraging existing surveillance infrastructure. So we started piloting NAS surveillance by implementing the Tier 1 CSTE NAS standardized surveillance case definition in Massachusetts, with births starting April 1, 2020. We were able to collect this data as NAS was incorporated as a reportable condition under existing legal authority to our birth defects monitoring program, BDMP, an active population-based surveillance system. And using this existing active surveillance infrastructure, we were able to abstract medical records on infants with NAS. We developed a REDCap database to house the data, which allowed for direct data entry into the system for clinical reviewers to have access to review and classify each of the cases. So just to give an overview of the flow of data, we start by receiving reports of cases of NAS from birth hospitals, and then medical record abstractors review the hospital records, abstracting the information into our REDCap database. A clinical reviewer then classifies the cases based on results from maternal and infant toxicology screens, infant symptoms, and other information, and then confirmed cases are included in a data submission to CDC. And this data is available for not just surveillance, but also research and for programs serving families impacted by NAS. So this is a matrix that compares the existing sources of NAS data in Massachusetts to our active pilot surveillance system. And you can see that our system has many strengths. It provides timely, high-quality data, and given that we adapted the existing surveillance system to incorporate NAS surveillance, it's also a highly flexible and simple system. However, given the lack of standardization in NAS case definitions and reporting prior to the development of this surveillance, there is no gold standard to compare our surveillance estimates to. So it was important that we estimated the sensitivity of our system to better understand what proportion of the true number of infants with NAS in Massachusetts our system was capturing. So now I'll move on to describing how we measured the sensitivity of our pilot active NAS surveillance system using Lincoln-Peterson Capture-Recapture methodology. After estimating the true population of infants with NAS in Massachusetts, we calculated the proportion of Massachusetts-born infants with NAS detected by our BDMP NAS surveillance system, which I'll refer to as BDMP NSS, to estimate the sensitivity of the system. So just to reiterate, to find the proportion of infants with NAS in Massachusetts picked up by our system, we had a two-step process. First, we used the Lincoln-Peterson Capture-Recapture methodology to estimate the true number of infants with NAS in Massachusetts. And then second, we calculated the proportion of infants with NAS detected by our system, giving us an estimate of the sensitivity of the system. So what exactly is Capture-Recapture? It's a methodology that actually takes root in ecology, used to estimate the true size of animal populations. Using two closed data sources, one can use a simple algebraic equation to estimate the true unknown population size. In our case, our two closed sources of data were, one, the BDMP NSS, which relies on hospital reporting of a number of NAS-related ICD-10 codes to ascertain potential cases of NAS, and second, birth certificates with the checkbox indicating NAS. And as I mentioned, using two closed sources of data, Capture-Recapture methodology enables us to use the algebraic equation n equals m times c divided by r to estimate the true population size, where m is the first capture, or the number of infants with NAS in our first data source, BDMP NSS. C is the second capture, or the number of infants with NAS in our second data source, vital records. And then R is the recapture, or the number of infants who appear in both systems. And then N is the true population size. So from April 1st through September 30th, 2020, here you see we had 456 infants reported to BDMP NSS and 181 infants marked as having NAS on their birth certificate during the same time. So our M is 456, C is 181, and R, the recapture estimate, those that appear in both data systems, was 159. And when plugging these numbers into our algebraic equation, we have 456 times 181 divided by 159, which gives us 519 infants with NAS in Massachusetts, or 15.2 per 1,000 live births. Now, knowing our true population size estimate, we can find the proportion of infants detected by our system. So since we picked up 456 infants with NAS in BDMP NSS out of the 519 infants in the estimated true population, this gives us an estimated sensitivity of 88% of the BDMP NSS. So we estimated that the prevalence of infants with NAS in Massachusetts using capture-recapture methodology was 15.2 infants per 1,000 live births, which is over 2 times the national estimate of 7.3 infants per 1,000 live births. And this estimate is consistent with what others have seen in Massachusetts and other data sources. So fortunately, BDMP NSS is highly sensitive, capturing 88% of NAS cases in Massachusetts. And given that there is a high number of cases of NAS in Massachusetts, this surveillance is a critical first step in developing standardized NAS surveillance that can allow us to monitor trends and provide timely and actionable individual-level data to inform resource allocation. There are some notable limitations to this work. The capture-recapture methodology relies on the assumption that each case has an equal chance of capture, or ascertainment, in either data source. And due to the different reporting mechanisms between BDMP, NSS, and vital records, this assumption may not hold. There's also a lack of standardized reporting of NAS across hospitals to both vital records and BDMP, NSS. Like I mentioned, BDMP relies upon ICD-10 codes reported from hospitals, and through stakeholder interviews and other research, we've found that there's a lack of standardization in how these codes are being applied. And then as for the checkbox on the birth certificate, this was added fairly recently in 2019, and it still remains fairly unclear to us how this checkbox is really being operationalized by the birth hospitals. But this work has clear public health implications. Surveillance has great potential to provide more timely estimates of NAS, and by performing medical record abstraction and clinical review of all cases, we have robust individual-level data that can provide us with actionable information for programs and outreach efforts. Our next steps for this work, putting this data into action, are to first continue improving NAS case ascertainment for our system so that we can better understand the burden of NAS in our state and allocate resources accordingly. Second, we will analyze the surveillance data from our system to identify disparities in NAS treatment, service referral, and enrollment, and then finally, we will share this data with programs serving families impacted by NAS. So I'll end by acknowledging Masa, Irini, and Kathy from our Center for Birth Defects Research and Prevention for supporting this work, Susan Manning, who is our CDC Maternal and Child Health Epidemiology assignee, Sharon Pagnano and Maria Vu from Vital Records, and Julia Brennan and Kayla Wiedemann from the Tennessee Department of Health for providing guidance on the capture-recapture methodology, and of course our amazing team of medical record abstractors. And as a final disclaimer, the findings and conclusions presented here are those of the authors and do not necessarily represent the views of the Centers for Disease Control and Prevention. Thanks so much for your attention.